I think when you have these, you know, inherent challenges or biases in the reimbursement aspects, it has to beg the question, does this or how will this impact the future of acquisition or passing down of these newer technologies? Where will they fit into? So I know that I believe in Manitoba, now in Quebec, they're going to be offering the Resume MIST procedure using a code with the same reimbursement as a TERP. So for the same, let's say, urologist or different urologists, one's going to go off and do a 250-gram pull-up, 3-hour endeavor, and then someone will go do a 5 or 6 minute Resume, and they get paid the same reimbursement. It kind of begs the question, will this influence the behaviors of those offering treatments? And as well, will that impact some people to maybe abuse certain things outside of indications? And I guess the global increase of its adoption in practice. So I think there needs to be, just a pause and reflection. And I think kind of looking at, maybe designating, kind of like in diving, there's degrees of difficulties. You're going to have one that's going to be more challenging than others, or another area of expertise that has to be considered. So the implications, I think that may limit or pose challenge as we introduce more of these MIST technologies, Optilume BPH, you got iTind, you got these other techniques, and they're kind of in an orphan state, at least in Canada, not covered by most provincial coverage programs. So the question is, how do you fit them in? Do you create a new slot and a new reimbursement appropriate to that, and make sure that they're all balanced? I guess what I'm seeing is a bit of an imbalance at present, and kind of where we fit this in, and well, we'll use a TERP code. So I guess that's great for the average urologist, but for those 5% of people who are brave and are kind of our leaders in advancing BPH in these more challenging anticoagulated larger prostates, I guess it's challenging. There has to be some sort of fight for them to say, look, this doesn't make sense. So the implications, I guess, are challenging, and as we bring on new technology and making sure that there's a parity of a fairness across the urological community in Canada. With this data, and I guess having reached out to the individual 10 province KOLs, there was Dr. Connor Forbes, who has done fellowship in HOLUP and kind of a leader in BPH in British Columbia, and he and his team have kind of responded saying, look, we should also do this for all therapies, including open simple prostatectomy and other types of cost analysis and adoption across Canada. So I know that they're sort of spawning interest of doing something similar and looking at the high data set of numbers of procedures performed and seeing if some of these factors we talked about have influenced or changed adoption. So where are we at with laser? Where are we at with HOLUP to get some kind of number of users? Is that growing? Is that remain stagnant? And how is this sort of new technology, all these technologies we want to bring to patients to have better outcomes, shorter recovery, longer durability, are they impeded because number one, access, and two, interest of the surgeon for the, inherent things we just talked about?